So good afternoon, everybody. I'm deeply honored and thankful to the organizing committee for having us here. So my talk of today is unoperated left to right shunt Eisenmenger syndrome. So a few months back, we were really thrilled with the newspaper cutting that came and said that there was a pediatric heart transplant, first of its kind, happened in the Pune, that is the Indian Armed Forces Hospital, in a child who is a son of Army veteran. But at the same time, when we go back to the clinical OPD, now the slides are not changing. When we go back to the clinical OPD, we see that a 14-year-old boy who has come with cyanosis and clubbing, and X-ray, there is suggestive of pulmonary artery dilatation, and there is a large VSD, which is a bidirectional shunt. And father gives a typical history that child got improved after 1 to 2 years of age, and now he's totally all right. But since the hole has not closed, we have come for the evaluation. So Eisenmenger syndrome, my dear friends, is a harsh reality in India, and it still exists. It was described almost more than 100 years back by Victor Eisenmenger when he found out a young adult who died of hemoptysis, and the autopsy showed that there is a large ventricular septal defect. And almost 50 years later, the Dr. Paul Wood, who designed the term Eisenmenger syndrome, when he found out that the pulmonary hypertension at systemic level was due to high pulmonary vascular resistance with reverse and bidirectional shunt across the large VSD in 1958. But even after 70 years of this description, and more than 100 years of the first case which came into our knowledge, we still stand probably at the same crossroad. So we have thousands of case series which describe about the congenital heart diseases in India, but CHD related PH incidents and the burden in India is still unknown. So once the patient comes to us of this kind, what are the challenges as physician that we face? Their decision on the borderline cases, probably this is one of the most important decision that we face. And then the treatment, which is supportive and medical therapy of PH related CHD, pregnancy in a young woman, and extra cardiac surgery, problems related to comorbidities, and of course, occupation. So as I was talking, the first problem that comes to the physician mind is in the borderline cases, because we always tend to close these holes and give some hope to the family that child may become better. And most of us follow this protocol. If the child is clinically operable, there is a left to right shunt, and there is no obvious signs of inoperability on ECG, X-ray, or echocardiogram, would be sent for surgery. But in borderline cases, whether either ECG, X-ray, or saturation levels are not clear-cut towards operability, then we send for cardiac cath. And if the PVR is less than 6 and P by S ratio, RP by RS is less than 0.3, then we can send again for surgery. But in gray zone areas where PVR is more than 8, acute vasodilatory testing is needed, and same protocol has been followed. But these numbers, are they always helpful to us? So in real-time scenario, in day-to-day life, the decision-making may not be that easy. So look at this case. He's a 2-year-old boy, a case of large PDA. There is no systemic desaturation. There is a mild cardiomegaly with mildly increased vascularity, but there is a large PDA and bidirectional shunt. There was mild LALV dilatation, but no significant left ventricular volume overload on ECG. So posted for cardiac cath, QPQS was 1.2 on room air, and on 100% FiO2, it increased to 2:1. And RP by RS was encouraging 0.6, and on 100% FiO2, it became 0.38. And since there was a duct, there is an option of doing post-occlusion testing. So we did the balloon occlusion of ductus arteriosus, and the PA pressure dropped to almost 60% of systolic. So this was thought to be encouraging data. There was a baseline step up from systemic veins to pulmonary artery, and that's why child was sent for PDA closure. So it was discussed that is PDA banding an option and leaving residual shunt in case the child is develop post-procedure pulmonary artery hypertension, it may help. So patient underwent PDA banding. But soon within 1 month of discharge, child came back with right heart failure, and there was a right to left shunt across that residual PDA. And luckily it was flowing, and child was, that's why, still alive. Otherwise, sudden cardiac death is also possible in case of PA crisis. So we have to bail out this case actually by keeping a PDA stent and opening that. so that the right heart failure can be improved and the syncope that child suffered can be minimized. So we learned it in a very hard way from a patient. And of course, most of the time it happens in these kind of situations. So we have to follow the protocols very meticulously and better not to close it whenever in doubt. So in the same time, this very interesting study came which suggested that if after balloon occlusion of ductus arteriosus, PA pressures are not falling less than 50%, then there is a good chance that there will be post-closure pulmonary artery hypertension. So if the PA and systemic pressure less than 0.5, there is a good chance that child would have no pulmonary artery hypertension. But if it is more than that, there is a chance of pulmonary artery hypertension. So answers we don't get even by the lung biopsy because the treatment plan is not going to change, and substantial risk exists of the morbidity and mortality during the procedure. So answers remain unclear in borderline cases, and best to follow the old teacher's teaching wherever in doubt, do not harm, do not operate, and take second opinion who has got better experience. Once you know that these cases are Eisenmenger, right to left shunt, on follow-up and on first diagnosis, we have to keep them on this risk stratification. The recent literature that has come 2022 from European Society of Cardiology has given actually all bedside tests, unlike the previous one where even the oxygen consumption was used. So here, most important things to see is the functional class and 6-minute walk distance. If it is more than 440, the patient is in low risk. That means next 1 year mortality is less than 5%. Whereas if it is less than 165, the next 1 year mortality is more than 10%. So always aim is to bring the patient towards the lower risk. Before starting to the targeted therapy, they always get benefited by the supportive therapies of all these kinds. Anemia is often overlooked in this patient because of polycythemia. So serum ferritin level should be done. If it is less than 100 microgram, that means there is a iron deficiency anemia and supplement should be given. There is no indication of routine anticoagulation because there can be a chance of pulmonary hemorrhage and hemoptysis. Diuretics are given only in case of congestive cardiac failure. Again, routine use of diuretics is not advised. They should be vaccinated for infectious diseases like pneumococcal, SARS-CoV virus, and influenza vaccine. Now come to the targeted therapy. In 2006, the breakthrough trial came, that is the BREATHE-5 trial, that is bosentan randomized trial of endothelin antagonist therapy. This is specially used 16 weeks therapy in the Eisenmenger syndrome patient. Only the bosentan drug was used in the adult patients who had functional class more than 3. So what they found that there was no major side effect of the drug, but there was definitely a significant improvement in 6-meter walk distance, and the functional class improved from class 3 to class 2. And there was no systemic desaturation, but there was no significant drop in the pulmonary artery pressures or the mean PA pressures or vascular resistance. But functional class definitely improved. Next year, there was a trial for the chronic sildenafil therapy as well, which gives benefit to these patients in a long run, that is around 6 months. So now that is almost 15 years back story. In the current era, that is in 2020, where do we stand with all these drugs? So this is a wonderful systematic review and meta-analysis that has analyzed all the anti-pulmonary vasodilator drugs, and it has found out that the endothelin receptor antagonist has definitely improved in the 6-minute walk distance. Where in the 2 studies, it has not improved. The drug use was macitentan. So it has got no significant improvement in Eisenmenger PH patient. The phosphodiesterase inhibitor and prostanoids also have been used and showed that significant improvement in the 6-minute walk distance. Now, whatever we are talking about till now was the monotherapy. This is a Compera registry, which is the largest world's registry on CHD related PH patient, and it started almost 20 years back, showed definite benefit in the patients of with the dual therapy as well, that is the bosentan and sildenafil. Sometimes we find a complicated patient with the large post-tricuspid shunt, like here there is a large PDA, but also there is a severe aortic stenosis and severe diastolic dysfunction of left ventricle. Yeah. So these patients patients will not be benefited with antiphosphodiesterase inhibitor patients and should be avoided these drugs. So heart transplant and extracardiac surgery should be heart transplant is of limited options still in India, and we are in developing stage of that. Overall survival, first 5-year survival is good, and it is almost 88%. And in simple lesion, they can still survive till 40 years if carefully managed. So Eisenmenger syndrome in CHD-PH is a harsh reality in India. Till now, the treatment aims only at improving functional class. Careful neonatal surveillance and availability of multiple cardiac centers, financial assistance of the needy family can be the way forward to treat these patients. Thank you.